Yeah, well, thanks very much for inviting me to give this talk. It's a very important topic. We have large numbers of patients who actually have asthma, and of course, we have a large number of patients who also potentially may have COVID. Now, we need to recognize that COVID actually falls into three potential phases. The first is a viral response phase, which is really where most people remain and is associated with viral upper respiratory tract infections, mild symptoms overall, cough, possibly diarrhea, headache, etc. A smaller percentage then go on to the pulmonary phase where you develop pneumonia, and that's the major cause for admission to hospital with hypoxemia. And a small group will go on to the hyperinflammatory response, which is associated with organ dysfunction. But obviously, the worry is that potentially asthmatics may be more predisposed to either of stage 2 or stage 3, or the more severe disease overall. So could it be that inhaled corticosteroids should be stopped given the fact that they are potentially immunosuppressive? But we need to balance this against the fact that if asthma is not well controlled, then of course virus-induced exacerbation of severity may well be worsened. And obviously, then if we suppress the degree of inflammation with corticosteroids, you may restore the antiviral defenses rather than actually immunosuppressing your patient as well. How do we treat patients? Well, you can see straight off that this is a poorly controlled asthmatic that obviously demised of the disease. And this type of inflammation is seen even in mild disease. And if we actually have a look at a cross-section of a normal airway, that there represents a normal airway. And as you can see, it has a thin wall. The actual muscle layer is thin. This one over here shows this extremely hypertrophic muscle layer. There's constriction of that, and there's hyperresponsiveness. There's significant amount of mucus that you have deposited, and an increase in the goblet cells that actually manufacture the mucus as well. But one of the problems, of course, is that you also get collagen and fibrocyte proliferation. And that really means that you actually potentially end up with fixed obstruction and fibrosis of the airways themselves. So now, how do you get asthma in the first place? And this really arises from an interaction between your genes, in other words, your genotype, and environmental factors. So anybody could, in fact, develop asthma at any age if they come into contact with a specific environmental factor that will interact with their genes to cause asthma. The type of disease or how it's driven, the actual mechanism is called the endotype, and I'll mention a little bit more about that now. And not everybody manifests exactly the same way as far as the clinical manifestations are concerned. And those clinical manifestations we call phenotypes. So you have genotypes, endotypes, and we have phenotypes. Now, just a word about the actual endotypes. Bottom line, there are two types of endotypes. The type 2 inflammation, as you can see at the top, and non-type 2 inflammation. The type 2 is the classical one that you're actually aware of, your Th2 cell with the release of multiple cytokines, the B cell, mast cells, eosinophils, and all of these result in the production of many mediators, leukotrienes, prostaglandin D2, histamine, etc., etc. So that's the classical one over there. This is the less classical one, where you develop asthma in association with environmental factors like irritants, pollutants, microbes, viruses, etc. And note, of course, viruses is a very topical cause at the moment that we're talking about. And the bottom line there is that it is mediated by neutrophils. And because it's mediated by neutrophils, then it is less likely to be responsive to corticosteroids. So neutrophil-mediated inflammation does not respond well to corticosteroids. So the first thing we need to know about any asthmatic is how well controlled they actually are. And many of you might actually know about the asthma control test, but it is an important measure of how well asthma actually is controlled. So you would be answering 5 questions. The best score would be 5 for each of those 5 questions. And then you would get bullseye and you would be perfectly controlled. If you're in the blue zone, and the blue zone would be 20 to 24, you would be well controlled, and that would be fine. Red would indicate that you are not well controlled. The 5 questions are easy. In the past 4 weeks, how much of your time did your asthma keep you from getting your usual activities done? How often have you had shortness of breath? How often did your asthma symptoms wake you up at nighttime or night dipping? How often have you used your rescue inhaler or nebulizer medication? And how would you rate your asthma control in the last 4 weeks? So 5 out of 5 for all of those, and you would be extremely well controlled. And you need to ask these questions because, in fact, if you don't, you will miss degrees of control because many people, both patients and doctors, underestimate how severe their asthma actually is. And only if you ask these questions, would you actually be able to determine where you stand. We need to know then, okay, from a control point of view, if you are on an appropriate corticosteroid regime. Remember, we now have large numbers of different types of corticosteroids. We've got the old-fashioned beclomethasone dipropionate. We don't have the CFC type anymore. That's the one that's associated with global warming and loss of the ozone layer. We've got budesonide as a dry powder. We've got cyclisinide. We've got fluticasone, and that's both the furoate and the propionate, and that the latter could be both dry powder and an HFA or an metered dose inhaler type. We've got mometazone and triamcinolone. Now, remember that we try always to use low-dose corticosteroids because increasing the dose actually does not increase the degree of control dramatically. It can do in some selected patients, but mostly all that you're doing is increasing the potential toxicity. So we try to keep them at low doses. And please note that the low dose is different according to the potency of the steroid. So all of those doses need to be recognized in terms of the steroid that you regularly use and what is considered to be a low dose, what's a medium dose, and what happens to be a high dose. When we're looking at control and asthma treatment way back, Eric Bateman looked at the GOAL study. And this was a study that looked at people who were either steroid naive, they'd never been on cortisone, some who'd been on an intermediate dose, and some who had been on a higher dose of corticosteroids. They had those 3 groups. Overall, 3,500 uncontrolled asthmatic patients who were initially given specifically corticosteroids in the brown bars, and then they added on a long-acting beta agonist. And then they extended the study for a longer period of time. This time, that was the phase 2, to see whether over time you got more control. In those that had not ever received corticosteroids, 70% achieved control, well-controlled asthma with just the steroid. 60% in those that were on a low dose regime or intermediate dose, and this one over here, which was the higher dose, moderate dose inhaled steroid, only 47%. But adding a long-acting beta agonist increased that to 78%, 75%, and 62%. So that does mean that a large number of patients will actually achieve adequate control. But there's still a group of patients who are not receiving appropriate control. There we need to look at other factors as to why they might not be controlled, including compliance and other things like allergic rhinitis or continued exposure to allergens or smoking, etc., that may well be factors involved in poor control. So as far as treatment is concerned, there are 2 strategies which have developed. Either you could use the fixed dose inhaled steroid with a long-acting beta agonist, an intermittent short-acting beta agonist, so you take your puffer to relieve you as you walk around during the day, or you could use the inhaled corticosteroid and formoterol and use that same device intermittently if you needed extra relief, recognizing and remembering that it has to be formoterol and not salmeterol, because formoterol has a rapid onset of action equivalent to that of salmeterol and phenoterol, which allows you to use it also as a reliever. But of course, when you use it as a reliever, you're also delivering a dose of inhaled corticosteroid. Now, one of the problems, of course, has been and remains an ongoing problem is that there is an over-reliance on short-acting beta agonists. And that's one of the reasons why we are always concerned when we see that people are ordering and using large numbers of canisters of the short-acting beta agonists. And if you actually look at this graph over here, this is the asthma deaths per 10,000 patient years, and the canisters of short-acting beta agonists that they have used per month. And as you can see, as that increases, so the mortality increases as well. So there's a direct line and relationship between how much of that you use and how much of and what the mortality happens to be. And in fact, exactly the opposite is shown when we look at inhaled corticosteroids. The rate ratio for death from asthma, and over here is canisters of steroids, and as you use them, so your mortality comes down. So absolutely critical that we recognize that the bottom line of therapy is treatment of the inflammation. Under treatment of that, and mortality actually goes up. And this then has been recognized in all of the big guidelines. This is the GINA guideline as far as asthma is concerned. And step one has moved towards a long-acting beta agonist and inhaled corticosteroid intermittently. In other words, you'd be using formoterol and the steroid in one container to be used intermittently rather than just the salbutamol, because even in that group of patients, inflammation actually does exist. But do remember, you must accurately diagnose the presence of asthma first, and that involves use of spirometry, a flow volume loop, and you must demonstrate that there is 12% reversibility when you give a beta agonist, which would indicate that you actually do have asthma. You could, in that step one, actually also consider regular low-dose steroid, but many of those patients will not do that because they don't have symptoms that would remind them that they actually do have asthma. Step two would be regular low-dose inhaled corticosteroid, and you could add other agents on, like a leukotriene receptor antagonist, if you actually had allergic rhinitis as well as the asthma. I've put in low-dose theophylline because it's cheap, but it is associated with a significant increase in side effects and is not particularly effective in terms of long-term control. The step three would now be low-dose inhaled corticosteroid and long-acting beta agonist, and therefore you could use that also as the reliever in that setting as well. And you could use a medium dose, high dose inhaled steroid instead of adding the LABA, but that would not actually be recommended there as well. The step four, you would go to medium or high dose inhaled corticosteroid. You could then add on tiotropium or glycopyrronium at that point, because remember that those agents, as LAMAs, long-acting antimuscarinic agents, are helpful in the poorly controlled patient who otherwise is on maximal therapy. And step five, we would use tiotropium or glycopyrronium. And there you might think about some of the biological therapies, anti-IgE or IL-5. Unfortunately, not that readily available in South Africa. Remember, I mentioned earlier that asthma control also depends upon control of allergic rhinitis, and I'm not really going to go into the therapy of allergic rhinitis, but it is an inflammatory process, and it has the same underlying endotypic mechanism that I showed you earlier in terms of asthma. So management must be directed to the nose, but extranasal symptoms should also receive attention. And there, intranasal corticosteroids, intranasal antihistamines, leukotriene receptor antagonists, and oral antihistamines are also potentially of value in terms of controlling the disease. Now, if we think about the new problem that we have in terms of the asthma and COVID-19, are asthmatics more likely to be admitted with COVID-19? So in Wuhan, originally, the prevalence of asthma was 0.9% versus The incidence, that was in the patients who actually presented to the hospital, was 0.9%, in other words, 5 of 548. And there was an overall incidence of asthma in the population of 6.4%. There may also be, and was postulated then, that those Th2-mediated types of asthmatics might have reduced susceptibility to asthma. In another study, 193 consecutive admissions, 8.8% had asthma. Most of those had a milder inpatient course and none required mechanical ventilation. There was one death from other COVID-19 comorbidities, and this rate was comparable with the prevalence of asthma of 7% in Ireland. In other words, it did not mean that asthmatics were more predisposed as well. Hospitalization, however, has been reported to be higher in those with severe asthma. In other words, those who've taken oral steroids in the last month. So we do try as far as possible to not to treat patients with oral steroids unless they are having an exacerbation. And if they are having an exacerbation, you should not deny them oral steroids, but don't leave them on it from a chronic point of view as well. This was a study from the UK Biobank data, 640 asthmatics with severe COVID. The asthma was significant for severity with an odds ratio of 1.39, but it was driven by non-allergic asthma. In other words, the non-Th2 type of asthma. That was where all of the increase in the potential for severity came. Allergic asthma, or the Th2 type, had no association with severe COVID at all. And in mortality stats from New York State Department of Health, the asthma was not in the top 10 comorbidities in asthma, even though 8 to 10% of the New York population had asthma. COPD came in after hypertension, diabetes, coronary vascular disease, and other CVS diseases, dementia, and renal disease. But interestingly, the type 2 inflammation is associated with a lower ACE2 receptor expression. And of course, that is the receptor that the SARS-CoV-2 virus binds to in order to enter our cells as well. So maybe that's why the type 2 inflammation is better off than the non-type 2 Th2 type of inflammation. And just to show you that from a diagrammatic point of view, if we look here on the left-hand side, there is your virus. It binds to an ACE2 receptor. It internalizes itself. It then utilizes the cell's DNA mechanism to make new constructs. And that then leads to the overall inflammatory process in a significant number of patients, capillary leak, procoagulant state, decreased breakdown of the clots as well, leading to many of the manifestations that we actually see in patients that have COVID. But when we actually look at this study, which then looked at the ACE2 receptor, there was no significant difference in ACE2 gene expression in the sputum between asthmatics and healthy subjects, suggesting that the asthmatics might not be at increased risk. In contrast, they do have an increased expression for ICAM1, an intercellular adhesion molecule, which is one to which cold viruses such as the rhinovirus will actually bind. And that might be why the asthmatics are more predisposed to colds and not so much predisposed to COVID-19. Male sex, African-American ethnicity, and diabetes all have elevated ACE2, and they also have that molecule which is necessary for cleaving the spike protein from the virus itself. And in contrast to systemic corticosteroids, inhaled corticosteroids in asthma was dose-dependently associated with reduced ACE2 and the TMPRSS2, which, as I said, is important in terms of cleaving the spike and allowing the virus to replicate once inside the cells. So how should we manage these patients? We do know that inhaled corticosteroid is associated then with an increased risk of upper respiratory tract infection, probably from that ICAM1 receptor. In vitro, corticosteroids may impair your antiviral immune responses, and some studies may show that inhaled steroids delay viral clearance, but others have shown normal responses. but they may be beneficial in coronavirus infection in that pre-treatment of respiratory tract epithelial cells in vitro with budesonide plus glycopyrronium and formoterol inhibited one of the endemic coronaviruses in terms of their replication and cytokine production. And there's even was a preprint and now published data which suggested that ciclesonide, much like any other steroid, could block SARS-CoV-2 RNA replication in vitro and inhibit the cytopathic activity. So don't stop the inhaled corticosteroids and continue to use them. Stable asthmatics that stop or reduce steroids are at significant risk of an exacerbation. And as opposed to patients with COPD, about 40 to 60% of COPD patients and 80% of asthma patients, in them, their exacerbations are due to viral infections, including the common endemic coronaviruses that we have circulating at the moment. And use of inhaled steroids either reduces the risk of becoming infected or modify the subsequent inflammatory response and the lung damage. So clinicians must be aware that there is no evidence to support the withdrawal of inhaled corticosteroids, and to do so is likely to be harmful in terms of decreasing control. And we've emphasized right from the beginning that control is the bottom line as far as asthma is concerned. This was a study looking at a large number of COPD patients and an even bigger number of asthmatics. The COPD patients prescribed steroids had an increased risk of COVID-19 related death. This was compared to LABA-LAMA combinations, an odds ratio of 1.39. Now, we have been moving away from the use of corticosteroids in patients with COPD unless they have an increased eosinophil count in their sputum or unless they have recurrent exacerbations. But LABA-LAMA combinations have been the way to go. When we look at asthmatics, high-dose inhaled steroids versus short-acting beta agonists alone were at increased risk of death, odds ratio 1.55, whereas low to medium dose were not, and that you can see crossed 1.85 to 1.54, meaning that there was no difference whatsoever. So we do, as far as possible, try to keep our patients on lower dose inhaled corticosteroid according to that graph that I showed you earlier. It's also imperative to distinguish if nasal symptoms are from allergic rhinitis and not COVID. Some patients will have regular seasonal type allergy and will have all the other features, itchy eyes, along with the itchy nose, sometimes rash, etc. If lower respiratory symptoms actually occur, coughing, sneezing, and shortness of breath, you must consider that there would be COVID as well. And remember that the virus spreads through droplets, through breathing, talking, coughing, or sneezing. So it always drives me crazy when I see people who stop to talk to each other in supermarkets and pull their masks down in order to communicate with their friends. That is the very time that the virus is transmitted. And similarly, those people who wear their masks over their mouths only or on their chins with their noses sticking out, that is of no value whatsoever. You might as well not wear a mask. Droplets will reach more than 1 meter to 2 meters from sneezing and coughing and will remain in the environment for some time or in the air, particularly in closed spaces, which is where the difficulty arises in terms of ensuring that people remain an adequate distance from each other and preferably in terms of staying outdoors. So remember cough and sneeze etiquette, social distancing, and wear your masks properly as well. There is no evidence to suggest that allergic rhinitis increases the risk for COVID, but patients should be cautious and comply with treatment regimens, especially the intranasal corticosteroid, as they decrease inflammation, decreasing viral access, and do not seem to increase the risk of actually contracting COVID as well. Your screening protocols need to be applied to anyone having worsening respiratory symptoms, in view of the varied and numerous clinical presentations. You need to have PPE if you're one of the screeners. You need to review inhaler technique and avoid known triggers, physical distancing, masks, and regular hand hygiene. And for those on biological medications, current recommendations mean stay on them, because that ensures that you also remain well controlled as well. If you absolutely need oral corticosteroids, you're having a moderate to severe asthma exacerbation that has responded poorly to bronchodilators, then you need to actually put the patient onto oral steroids, because they hasten symptom resolution and decrease the risk of admission. Remember that compliance is always a problem amongst all of our patients, and I would draw your attention to the bottom paragraph here, where of 59 patients, 47 of those were actually eligible for novel therapy, those biologicals that are enormously expensive. They were not well controlled on maximal therapy of the standard medications. Now, 32 of those had electronic monitoring data attached to their inhalers so that you could tell whether, in fact, they were using those inhalers or not. And in fact, non-adherence actually occurred in 50% of those, even though they assured their doctors that they were using their therapies appropriately as well. So this could be, if you added the 7 who did not have the electronic monitoring, you would go up to a possibility of 59%. So overall, at least 50% of those eligible for novel therapies are actually non-adherent. Very difficult to understand. We don't know why patients insist they're taking them, but in fact, they actually aren't taking their therapies. So nebulizers. Nebulization is an aerosol generating procedure that can increase the risk of aerosolization. So it's advised that where possible, people should use a metered dose inhaler with a valved holding chamber or a dry powder inhaler, because that decreases spread of the virus in healthcare settings in particular, and in closed environments in particular as well. What about antibiotics? In all of the data sets, your procalcitonin on patients on admission is low. This correlates with findings from influenza, SARS, and MERS, where they have pure viral infection and you don't need to actually add an antibiotic. And just to add to that, that azithromycin does not offer any benefit in COVID. It is a virus. And azithromycin does not decrease the inflammation and has no benefit in the setting and should not be utilized as part of your therapy for COVID there as well. Acute and chronic symptoms. Some of these may in fact be due to a nicotine adenine dinucleotide deficiency. This would decrease the activity of a molecule known as SIRT. This is imperative for that SIRT to function. You need zinc and NAD+, which then activates the SIRT, and that modulates the TNF-alpha, interleukin-1 beta, and IL-6 production. There is also hyperactivity of an enzyme known as PARP1. That then will decrease the amount of energy available. And of course, NAD+ is responsible for energy production, in specifically ATP deficiency, energy loss, and subsequent cell death. And you can therefore impair the SIRT function, and replenishment by nicotinic acid plus zinc have the potential to ameliorate the pro-inflammatory cascade. And as you can see over there in the red is NAD+. There are a number of different mechanisms by which you can actually decrease NAD+. It is degraded here by fasting or exercise or caloric restriction, various inflammatory stimulation, also via T cell activation, and by DNA damage, which is then utilizing NAD+ to activate that enzyme. And that may be one of the mechanisms by which the disease causes its clinical features. Vitamin D, this was a small study looking at those admitted to ICU. Their vitamin Ds were significantly lower at 14.4, 22.4 in those admitted to hospital, 30.3 in those with mild symptoms, and 25.4 in the controls that didn't actually have COVID. So it's possible that a vitamin D level may be actually adequate. And we would recommend that you could use this type of regime from the point of view of both acute and chronic COVID. Nicotinic acid, specifically not nicotinamide, 35 milligrams daily, zinc 5 to 10, vitamin C 500 milligrams twice daily, and vitamin D 2,000 international units daily, and not more than that, because you can then get toxicity. So thank you very much for your attention during this talk. I think it's a very important one, and I think we need to impress upon our patients that they need to get adequate control and they need to continue their appropriate therapy and don't divert themselves away from their asthma therapy to unproven therapies such as ivermectin and others that become popular over a period of time. Thank you.